So maybe we can get started. So welcome everybody. So this is a webinar organized by the European Burden of Disease Network that most of you might know, but I'm going to give a little bit of a background of who we are in a few seconds. So today the topic is about the non-fatal burden of cancer. And we are going to dive into some methodologies that were used into two national burden of disease studies. And we have today Elena and Robbie. So Elena from the Robert Koch Institute in Germany and Robbie from Cienzano in Belgium, that are going to describe a bit the methodological insights and choices that they took for their own burden of disease studies. And at the end of their presentations, we are going to have a bit of a panel discussion to dive a bit into deeper on the differences in the methodologies. So as promised, I'm going to introduce a bit the European Burden of Disease Network. So we started being active in 2019, end of 2019. The picture you see here is from February 2020, the time of our first working group meeting. And this network started thanks to a cost action grant as a technical platform to integrate and strengthen capacity in burden of disease across Europe and beyond. So since 2019, we have been creating this sort of platform to help people and researchers working in burden of disease to start their own burden of disease or to enrich their studies. So as I was mentioning, it started with a cost action grant that allow us to have some resources to be able to meet and to strengthen this network. But after 4 years, the grant is finished, and now the network will continue, but as a non-profit organization. So all the members that are part of this network will automatically be part of the organization, the non-profit organization or association. But it's always possible to continue enroll and continue in the activity and join in through the website that you have here. So until now we have more than 350 members. You see here on the left-hand side the pictures of the few of the many times we were able to meet and present our work and work towards this network. And the nice thing is that we represent almost all countries in the European Union, plus other countries outside of the European Union or Europe in general, and some other international organizations like WHO and the European Observatory. So the three key cornerstones of the network or corner activities of the network is to work together in joint research activities. And for this, we created a few years ago task forces that focus on specific topics and work together in these specific topics. These have been very active in the past years, also with some publication that came out of these task forces. So do not hesitate to go on the website and join one of these. Another important element of the network is the capacity building around burden of disease assessment. We have been organizing throughout the cost action some training schools that were very successful. And so we decided to continue with this activity in the association, but more towards summer schools. And I'm going to show you a bit our summer schools in a second. And then, of course, one of the main things of the network, as the word says, is networking. So we are very active in participating to conferences, activities around burden of disease. We have a newsletter. We publish many information in the newsletter or in the website. So you can stay up to date also by visiting our website or subscribing to the newsletter. An important part of the new association regarding European Burden of Disease Network is the summer school that follow a bit the trend we had for our training schools that were open to the members of the network. So this year we launched 3 summer schools for which the registrations are still open. You can go to the website, and I see Brecht put the link in the chat. And you can enroll for the general concept burden of disease summer school that it's going to be in July and towards the end of July and beginning of August. The burden of risk factor and the burden of infectious diseases both in August. And all these 3 summer schools will be in Ghent, beautiful as you see in the picture. It is in Belgium. So do not hesitate to reach out if you have any questions or to join in registering in the website. But now I'll go back to the main the main reason why we're here today, which is the webinar on the non-fatal burden of cancer. And I'm going to leave the floor to to the speakers today. I said at the beginning, but I repeat it now. So the settings of the WebEx webinar here don't allow you to switch on the cameras or unmute yourself. So if during the panel, during the Q&A that we will leave at the end, you will have any questions and you would want to speak, you can raise your hand and we will unmute yourself. Of course, during the presentation, you can always put questions in the chat we will make sure to answer them. So I'll maybe ask Elena to share her slides.
Just a minute.
Yes,
Hello,
no
everybody. Also, good morning also from me, and thank you very much for the invitation to present our results or our methodology on estimating severity distributions for the cancer diseases. I'm looking forward also to the discussion. I just want to point out that this work was a teamwork, so it was not I am presenting, but I must thank all the team that participated in the project. Later I will show you how the project was developed. So the outline of my presentation, I will just say several words about our German burden of disease study, and then I will quickly proceed to the cancer models, and we will talk shortly about the prevalence and mostly about the severity distributions. I will show you also our results and a very short outlook of what we are going to do next. So the German burden of disease study was a pilot project financed for 3 years. We did estimations for 1 year only, namely for 2017, and the coordination was done at our institute, but we cooperated with the German Environment Agency and the Scientific Institute of the biggest health insurance company in Germany, which are the data holders and who made it possible to implement all our suggestions and disease modeling. So we were very lucky to have them. The important data sources that we used for mortality, of course, the causes of death statistic, this is a register in Germany, and for the morbidity, namely the health insurance data, but also some survey data and vital statistics. We included in our estimates 18 diseases, and out of them are 4 cancers, for which I will talk about today. We also have stratification of our estimates according to sex, age, 5 years age groups, and region. We have our estimates on the 16 federal states, but also we could go further down and provide estimates on the 96 spatial planning regions. And all the results and publications that are available up to now, all you can find at DALY RKI.de. So the cancer models. For the disease definitions, we used the GBD definition, so we strongly oriented on them. We had a look at 4 cancer types. colon, lung, breast, and prostate. And for each of them, the ICD codes for the diagnosis, treatments, and metastasis were all included and predefined from the GBD. So we had, when we had the definition of our cancer cases, we had access, or our partners had access to the inpatient and outpatient data. So in the inpatient data, we could have a look at main and secondary diagnosis. And in the outpatient data, probably it's worth to mention that we consider the confirmed cases or diagnosis when they appeared twice in the year. So the records in the insurance company are coming in quarters. So at least 2 quarters in the year then were considered as a confirmed diagnosis. This is a general slide showing how usually one estimates the years lived with disability. So we need the prevalence, we have the severity distributions, the duration, which for the mostly non-communicable diseases, it's 1 year, so it's mostly not relevant, and we have the disability weights. In our case, we have used them from the GBD. So all this information then is provided to estimate the YLDs. In the cancer disease modeling, we concentrate mostly on the prevalence and the severity distributions because this is what was coming from our own data. So we also oriented on the prevalence definition on the GBD. So we also defined 10-year prevalence. And our assessment period was 2017. And as I mentioned, the data and the claims data is in quarters divided. So we had a look at all our insurance patients, insurance persons in each quarter, and we track them backwards 10 years. And in case somewhere was a code that was facing the definition, like the ICD codes that I was showing you, then this was validated and the person was considered as a prevalent case. So it was more or less individual level assessment. This is very simplified way of presenting this prevalence definition. In reality, it is a little bit more complicated, but I wanted to concentrate mostly on the severity distributions. That's why just a short description. So the cancer phases, the severity distributions from the global burden of disease are mostly divided into 4 phases. So generally spoken, we have a therapy phase where some therapies are taking place or surgeries. Then we have the controlled phase where no treatments are recorded for the period. We have the metastasis phase, which is usually available through the information through the ICD codes, and the terminal phase, which is tracked from the date of death and assigned as a terminal. This is the general case. And so we had a look at our data sources to see what information we can use for what to be able to assign people to a certain phase in their disease. So we used the ICD code diagnosis also not only for the prevalent definition for the cases, but also we had information if there was a metastasis in the patient diagnosed. We had information on the medication that was used for the patient, so we could use this information to assign to the patients if they were taken chemotherapy or any kind of opioids. We had the information from the treatment in hospitals that our patients have received, from which we could use the information for cancer-specific surgical codes, for chemo or radiotherapy. And from the outpatient treatments, we could also take information if there were radiotherapy taking place or any cancer-specific treatments. So all these kind of data sources were used for the information to assign to the patients the severity phase that they were at the moment. How we operationalized all this. So for each cancer disease, we were able to determine the phases on a daily basis for each patient. So the metastasis were determined from the reported quarter. I already mentioned we had a look quarterly on our data, and also for the previous 3 quarters, so that we could have this information for the whole assessment period. For the therapy phase, we allowed multiple phases. So I will show an example. The therapy could appear several times in our assessment period, and we were able to extrapolate all this information from the insurance persons in this company to the whole population in Germany. There were 2 external data sources that we used for the duration of the therapy phase of the phases. Namely, for the therapy phase, GBD has published cancer-specific durations, and we have taken them over. So we have assigned this duration to our patients. And we also have used the terminal phase, also predetermined from the GBD, where for each cancer taken from the death the death date 4 weeks before the death was considered that the patient was in the terminal phase, and this we applied also to our data. So this is an example of how it could look like theoretically. The records, this is 1 quarter, 3 months, each month 4 weeks, and we have the different diseased persons. So it could appear that for the whole quarter, a person is in the controlled phase, there is no treatment received. Then it could be that the status changes, and for instance here a person has a therapy phase where a kind of a therapy is recorded, and then for the rest of the period no therapy was recorded, so the person was considered to be in control phase. It could happen also that we have recorded a person with metastasis, and then we have the death date. So we assign the last 4 weeks of this as a terminal phase. It could also happen that theoretically that we had a control phase and then a death happened. So we assign again the last 4 weeks as a terminal phase. Or we have in the beginning of our observed period observed death. So we have for this also assigned a terminal phase. And an example with the multiple therapy phases, so this is just in theory, I'm not sure if exactly so it has appeared in our data because this is pretty short for a quarter, but basically it's allowed that there is a therapy phase, some therapies are taking place, then there is no for a certain period, and then another therapy period. And these severity distributions are then estimated for each quarter of the year, and then from the quarters for the whole period aggregated. So how does it look for the here is an example from the breast cancer. So nevertheless the modeling of the cancers differ a little bit because they have something specific in them, like breast cancer has in the control phase 2 subgroups. For the diagnosis we have estimated 3.3%. But here we differentiate between this controlled phase or if the person had mastectomy or not. So we have a big part, the biggest part in the controlled phase without mastectomy, but we also have quite a high proportion of people in the controlled phase with mastectomy. And then in our case, we could estimate about 11% that were in the metastatic phase and 0.5 in the terminal phase. For the other cancers, there is also a little bit of different differentiation. So the general phases, the controlled therapy, metastatic and terminal phases are assigned those disability weights. However, for the prostate cancer, we also could differentiate in the controlled phase if there was impotence, incontinence, or both. So these people were assigned different disability weights, and a little bit accordingly the severity distributions have a little bit of other groups. For the colon cancer, we had in the controlled group also differentiation between having with stoma or without. And for the lung cancer, we had only the four basic phases. So I will show you some results. First with the prevalence. These are preliminary results that are not published yet. We are working on trends. We have for the last 5 years, the available data estimated the prevalences, and we see for the breast and prostate cancer a kind of increase, and less so for colon and lung cancer. And the highest percents are also for the breast and prostate cancer. They are more high observed. To come back to the severity distributions, which is probably most interesting for you, this is the general severity distributions for colon cancer. The biggest part of our patients were in the controlled phase without stoma. However, here is one small part with stoma and quite a higher part of metastatic phase. However, these distributions differed highly according to age. So in our YLD estimations, we were using the severity distributions according to age. So we assigned to each age group a different severity distribution. So it is very interesting to see that in the middle ages, we have a kind of more burden from the YLD. So we have here higher proportions of people with a metastasis. And in the older ages are coming a little bit more the terminal phases to be seen. Similarly, also for the lung cancer. However, here I wanted to point out that the terminal phase is relatively big, and this is probably mostly connected to the high mortality that we are observing in the lung cancer. I will come back to this also later. And the severity distributions are also very much different according to age. And we again observe in the middle age group also the more complicated cases, namely the metastatic cases. Similar is for breast cancer. We have the controlled phases are those two phases in the middle. But interesting, you see that with mastectomy are also in the middle age group, and later in the age groups is mostly without mastectomy. We can discuss this later if there is time. And so just to show for the prostate, we have a little bit more categories for the controlled phase. So we have the biggest one is luckily without impotence and incontinence, but we still have a big proportion with impotence, with incontinence, or with both. So we have differentiated this, and this also the same pattern here. We start the observation above 40, so the ages here a little bit shifted, but we also have in this middle age a little bit more complicated cases like with incontinence or metastatic. Also, somehow it is not a full picture if I'm only showing the severity distributions and the morbidity part. So the mortality is also very important. So I decided to include it also in this presentation. We see that the lung cancer is the biggest killer compared from all these four cancers. So it has extremely high mortality part. And the prostate and breast cancer have a higher morbidity part compared to the two other cancers in all age categories. And this is our estimation for the mortality. Is you see that in Germany, the coronary heart disease has the biggest part. But if you sum up all the cancers, then you see that basically we have also quite a high burden from cancers. And if we concentrate only on the neoplasms, we see that lung colon, breast, prostate, and pancreas have the biggest part out of this. So pancreas, we haven't had a look in our estimates up to now. It is planned for the future. Just some further results from our whole burden of disease estimates. All the diseases that we had a look up to now plotted here, and just to show that each of them has a different share in terms of morbidity or mortality. And some of the diseases are not having any mortality part, and the cancers are belonging to those diseases that are consisting mostly of the mortality actually. However, prostate and breast cancer are the ones that have a higher morbidity part. Another further description of our results, we have plotted everything according to age and to YLL and YLD contribution. So we see that in the colon, a little bit more men are burdened than women, and we have relatively high mortality, but also quite a big part of morbidity. Another picture is observed for the lung cancer. So we have here definitely much more men that are affected, and this could be because of the risk factors like smoking. And we have a very high mortality compared to the colon cancer here. And it's also shifted a little bit to the younger ages. The burden. Totally different picture for the breast cancer. We have very few cases for the men, so I'm not talking about them. But we have with age also increasing cases, but luckily a little bit more YLD part than mortality. And compared to this, the prostate occurs a little bit later in the age and also has a higher morbidity part. We also had, as I mentioned, our regional estimates. So for some of the cancers, we don't have any pattern to see, but for the lung cancer, for instance, in the more industrial areas, we see a higher YLDs, or we have in the breast cancer kind of a east-west pattern. So shortly for our outlook, what are we doing now? We are estimating, as I mentioned, trends for all our diseases, not only for the cancers. We are also including 6 further diseases, not only from the non-communicable, but also communicable diseases. We are working on estimations according to deprivation areas. I will show one example here later. And we are also working on methodology for multimorbidity adjustment. Up to now, we have done this from the independent assignment, but we are developing this methodology, and we want to apply the dependent assignment. So this would be most probably a possible topic for another webinar when we are so far with our methodology. We are also planning to have forecast estimates once we have the trend estimations, and we are not that advancing with the risk attribution as we have liked to, but we are still on the track. So one example, what I meant with the index, with the deprivation index. So we are working on bivariate maps, which will be published soon on our webpage, where we plot the correlation between the DALYs and the deprivation index. So the higher DALY and the higher deprivation index leads to very dark blue. And the low DALY and low deprivation index is the very light blue. So ideally, if you have a linear correlation, you will observe only these 3 colors. In the case of the lung cancer, we have a relatively high correlation, so almost linear, but not completely. And one can see that in the southern part of Germany, which is lower deprivation, also observed lower DALY due to lung cancer. In the western parts, mid, so mid deprivation and middle burden, and with the dark blue, which are mostly from the eastern part, are the higher deprivation and the higher DALY. But we are working on this, and we are also working on the explanation on this. So thank you very much.
Thank you very much, Elena.
Vanessa, shall I end up my presentation?
Yes, you can. You can switch off your sharing. People can put questions in the chat or keep them for later. So I'll give the floor to Robbie. That you will see he used very different methods because we have different data in Belgium. So it will be interesting then to have a discussion on the different methodologies. So Robbie, please.
Okay, here we go. So thank you all for joining this interesting webinar. So I will talk about how we estimated the burden of cancer in the Belgian National Burden of Disease study. So I will first start with a small overview. So in this presentation, we will first see a bit the background and the link to the Belgian National Burden of Disease study. The data that we estimated, or the estimates that we have, are also incidence and prevalence based, and the results of these estimates are also available on the website that I will show a bit later on in the presentation. We will talk about the disease model, some key results, and then some limitations, strengths, and the future. But first, I will start with some background. So as I explained already before, the estimates that I showed today are actually estimates within the Belgian National Burden of Disease study, in short BoD. And the idea is, of course, that we try to assess the impact of morbidity, expressed then as years lived with disability or YLDs, and the mortality, years of life lost, for the most important diseases in Belgium. And of course, you can imagine, as it is in many other countries, that cancer is, of course, one of the included groups, which can have, of course, primarily a very high mortality rate, but also an sufficient or an important amount of morbidity associated with them. In general, the methodology is split up in two, where we have a YLL estimation, which is actually based on the cause of death register that we have. So we have the Statistics Bureau in Belgium, Stadbel, and we receive a cause of death register from them. And based on that register, we can calculate the mortality related burden expressed as YLLs for actually all causes of death that were registered in Belgium. The YLD estimation is a bit different. If we're lucky, and we are quite lucky for cancer, there is a registry available. And for this exercise for cancers estimates, we were able to use the Belgian Cancer Register for this. Or if no register is available, we have to do an ad hoc analysis. And both components are then combined together in a DALY estimate, as you all well know, which are presented in a different app than I will talk about today, but are also presented, of course, in the Belgian National Burden of Disease study. Likewise to Elena, I want to emphasize that, of course, this was all a team effort. You can see that Vanessa is actually the better expert compared to me. So she was able to publish this as a first author in BMC Cancer. So if you want more details on the methodology, you can always contact her, or Brecht, who was also very much involved. I was rather a side player. So I might have the very easy job later on when you have questions to refer them to Vanessa or Brecht. So I will talk a bit about the general approach. So how do we estimate? I will focus also in the presentation on the non-fatal burden of cancer. We also have YL estimates, but these will not be discussed in this presentation. So as already explained, we were able to use the data that is available from the Belgian Cancer Register, and they have information on cancer incidence and also information on cancer survival. The information that is present in the Belgian Cancer Registry for cancer survival is, of course, the result of a linkage that has been done between the cause of death register at Stadbel and the Belgian Cancer Registry, where they can see which patients have died or which patients have survived. And the main idea is, of course, to have these estimates all available, and we're quite proud of this, that we are always able to present our results in some kind of online application that is easily accessible for everyone. And also for this project, we have an online application where you can explore this YLD-related estimates for the burden of cancer in Belgium. So as I explained already before, the non-fatal burden of cancer is actually split up in let's say, two methodologies that are presented on the website as well. So of course, we have this incidence-based approach and the prevalence-based approach. The advantage of an incidence-based approach is that you could also include the current, the future burden. So when you're thinking about preventive measures that you want to take, then this might be the better estimate to use to check how you can also avoid future burden of cancer incident cases. So if you look to this small graph, and I think this is also a graph that is, that you're all quite familiar with. Let's say that on the y-axis you have quality of life, right? And this is the 100%, and this is the ideal life expectancy. So on the x-axis you have age, and then of course, unfortunately, often people die before their ideal life expectancy, and the red part, which was a bit made transparent here, is on the YLL. So this is not yet included, or is not counted in this incidence-based approach for the YLD component. And then the green part is what you lose in quality of life while still surviving with cancer, but that is lost due to living with the disease and due to morbidity. And as you can see, if one bar is actually 1 year, if you look to the incidence-based approaches, then of course you count the different years to come as well. So the future burden related to the fact that you had a cancer diagnosis in an initial year at an initial age. This is of course very different from the prevalence-based approach, where we try to count only the current burden, so the burden in a specific year. Now you can see that this part is also made a bit transparent, because it's also not included in the burden estimates, which is prevalence-based. So we only look to 1 year. And then you have the advantage that you can evaluate, of course, the current impact that diseases can have on the healthcare system. So this is quickly to explain why we also think it's important to, when this is, of course, a possibility, to present both estimates. Some words on the Belgian Cancer Register. So there are some advantages on this register. First of all, it's a population-based registry that has incidence and cancer survival estimates available. So because it's a population-based registry, we can also be quite sure, or we are even quite sure, that it's almost exhaustive. Of course, probably will not cover 100% of the Belgian population, but it will be very close to the 100%, which is a very large plus. So it's also nationally representative. So for some of the diseases, non-cancer related, we often have to rely on data that might not be nationally representative, that might be related to a specific region where the register is very active and maybe not that active in other regions. And it's also exhaustive for the different regions within Belgium. So what they do is they also collect data from the oncological care program, so a clinical network, and pathology laboratories, a pathological network. So there is actually a lot of information on cancer available in the Belgian Cancer Registry. And actually, this is quite similar to the presentation of Elena. There is also this ICD-10 classification of cancers, or that's at least the transformation that is done, where we in this exercise focused on a group of in total 54 cancers. So this is the start point. This is where we start from. So we start from the data of the Belgian Cancer Registry. Main advantage, it's national representative, it's population-based, it's exhaustive, and it has a lot of information available. And then we go to the disease model. So in the disease model, we actually made a disease model in line with the GBD methodology. And this is for the health states with disability, weights, and durations. And we use this 10-year survival period as a reference point to estimate the cancer burden. There are actually two first stages that are made. You have the survival state. And in the survival state, over this 10-year period, you can either have a health state that is related to diagnosis and the primary treatment that you would receive during this time, and a control phase, which is then actually the chronic phase after treatment. So this is actually also emphasizing that it's very important to consider cancer, or that we, at least in our exercise, consider cancer as a chronic disease. So after treatment, you still, of course, have some disability related to the disease. You have also some fatal states, which has different health states included. This can be a terminal one, a diagnosis one with the primary treatment that you receive, a metastasis state, and then a control stage. This is actually also quite similar to what they did in Germany and that Elena presented. They also use these different health states that are related to or aligned to what the GBD health states are. In addition to this, for some cancers, for example, colorectal cancer, there can be specific complication rates and assumed proportions, and this may be a difference. This was not data driven. So to assess or to also have patients related or linked to the specific complication and proportions into these different complications, we used expert opinion. So experts were invited to fill out a survey, and in this survey they could give the estimate that they would provide for complications related to specific cancers and the assumed proportion of people that would suffer from that complication. So it's not data driven, it's based on expert opinion. And these proportions given by experts for specific cancers and specific complications were then also averaged. But of course, you can see that this is a large source of uncertainty, and we will come back to this later when we talk about limitation, strength, and future plans. So this is quite different. So this is about the health state. We look to the 10-year survival period. But the actual modeling is, of course, done by a microsimulation, or is done in this study in a microsimulation model. So to go from this incidence to the prevalence with the different health states, we use a microsimulation model. So the information on incidence was based on the Belgian Cancer Register. The data for incidence was available from 2004 to 2021. And I will go immediately to the fourth bullet point. This, of course, also means when we look at the 10-year survival rate, that prevalence data is only available after this first 10-year period. So the prevalence survival data is currently available for the year 2013 to 2021. So the 10-year survival information that was received from the cancer register is based on a Kaplan-Meier analysis. So this means that we have survival proportions for the different cancer types. This can be divided by age, sex, and region for the 3 main regions in Belgium. But the categorization of age is actually also dependent on the number of cases. So for some of the cancers that are very frequent, we can use a very narrow age group. For cancers that are not that frequent, the age categories could be a lot broader. And then to come up with this prevalence estimate, we use an actual microsimulation model where an incident case or cohort is then split up, and this split is done on a yearly basis. So we have survival probabilities per year, and then we check if someone survives. And if this person survives, they can go through at most 2 health states. They can have their primary treatment and diagnosis phase, and afterwards they can go to this control phase. And this is done on a monthly basis. So by month, patients can switch from phase to phase. Of course, in theory, they cannot switch back to a previous phase. So there is some hierarchical order, which does not allow them to switch back. The same is for the fatal phase. So that's, of course, with a different probability, also looked again on a yearly basis. And then month by month, they can go to the different health states, where the end stage, of course, will be that they will not survive this 10-year period. And here as well, if the first health state that is already assigned to a patient is a terminal phase, then of course it stops here and they will no longer go to a second or another health state. And the prevalence data is then actually, or the prevalence estimate, is then actually the sum of the time that is spent in these different health states. So the sum of the person months in each of the health states. And specifically for the YLD estimation, this is of course weighted for the disability. Based on the disability weights were also in line with the estimates of the GBD. So the estimates that we have for the different health states and the prevalence-based estimations are very much simulation-based. So this is very different from the study in Germany, where they could rely on a lot more data sources. And the complication rate is also based on expert opinion and also not data driven. So this is also a large difference or a major important difference between both studies. For the next slide, I will go through the some key results. But these are all available on the website. So we have some, in this graph, you have the incidence cases, actually the rate per 100,000. And by different cancers, they are age standardized. So the effect of age over time is left out for both men and women in the entire Belgian country. It's incidence based, so we have information from 2004 to currently 2021. And here you can see that there is an important growth that is seen. And I think this is something that is also seen in other countries of malignant melanoma of the skin, so skin cancer. For other cancers, we can see that there is more or less a steady state. Here we can see a small increase during a specific year. This is from colon and rectum cancer. This can be largely explained by a screening program that was put in place. So there was a screening program that was put in place, and that's why they picked up much more incidence cases in that year. But you can see afterwards that this stabilized out again, and even is slowly decreasing now. If we look to the top cancers, so the top 20 cancers, based on the prevalent years with disability, we can see that prostate cancer is #1, followed by breast cancer, colon and rectum cancer, non-melanoma skin cancer, and then lung cancer. So I think this is very similar to the results in Germany, where of course lung cancer, colon cancer, breast cancer and prostate are very important causes for disability also in Belgium. If you look to differences between both sexes, so this is a graph where you can see this is the averaged effect, so it's for men and women combined, the number of prevalent cases per 100,000 people. And you can see that the burden of cancer or the prevalence of cancer in Belgium is higher for men compared to women, which was similar to what has been presented earlier by Elena. You can also see that there is maybe a slightly greater increase in women compared to men, but the difference, of course, remains by eye much or less stable. And when we look to the incidence-based results, so these are the different incident years lived with disability compared to the prevalent years with disability for both sexes and all ages, we can see that this is more or less the same. So the top 5 is in both prostate cancer, breast cancer, melanoma, colon and rectum cancer. So there might be some switches of position, but in general, we can see that for both approaches, the top cancers and the ranking of cancer remains more or less the same. Some limitations and strengths, and afterwards a slide with future plans. So the Belgian Cancer Register provides very complete data. So it's normally exhaustive for more than 95% of the Belgian population. And we also have national survival curves readily available that we can use and incorporate in the estimates. The disease models that we used, this might be a limitation, of course. So the disease model that we used is in line with the GBD. Can also be looked at the strength or comparability, but the duration in the different health state is related to this, and this might be very different in Belgium. So this is something that we could look into, analyze, research in future plans. And the uncertainty is currently not formally assessed for all the different components that are combined together in the microsimulation model, because as you are probably all well aware of, microsimulation and simulating these different health states and the survival probabilities takes, of course, a very long time. And if you want to include uncertainty on all the components that come together in this prevalent and incident-based cancer, while the estimates, then this would take or consume a lot of time. But in the future, we will try to address this with full uncertainty analysis, hopefully, and also data-driven, not only maybe complication rates, but maybe also health states and linked severity distributions. So as I explained already before, so we have our estimates available online. So you can all check this website, burden.cnsn.be/shiny/cancer, where you can explore the different estimates by age, by sex, by the different regions in Belgium. And I wanted to show this website, but maybe for a time, I will go to my last slide to thank you all for your attention. And if you have any questions after this presentation, you can always contact me by email, and then I might have to refer you to Vanessa to answer a very complicated question. So thank you very much for your attention.
Thank you, Robbie. So we are left with like more or less 5 minutes for questions. So I see that Romana had before like questions for Elena when you were presenting the distribution by age of the severity distributions. And she asked if you had a look at the standard deviation by sex for these severity distributions.
Yeah. The answer is yes. I just didn't present it, but yes, we had a look.
Okay.
Estimated them accordingly.
So I don't know if there are any other questions. I don't know, Brecht, if you see any hand up. No. Okay. Maybe I'll pick up on the last part of Robbie regarding uncertainty. Because yeah, of course, like you presented two very different methodologies, and yeah, it comes with yeah, advantages and disadvantages for each. So maybe I wanted to ask Elena and Robbie to reflect a little bit of yeah, the uncertainty behind their estimates, and yeah, regarding data sources and the method used, very shortly.
Yes, for all our estimates, we have also applied uncertainty estimation. My colleague Michael is the one who performs this. I don't know if he wants to say some words, but basically, yes, we estimate all kind of for all our indicators uncertainty based on Bayesian methods with a replication of 1,000 times, and we orient also on the methodology of the GPT. But yes, we do this.
Because for your method, the source of uncertainty, maybe also the data source, if I understood correctly, is it a sample or is it for the whole Belgian, Belgian, Germany?
So our it's not a sample, it's in the insurance people in the biggest health insurance company, which are about 30 million of people. And they are extrapolated then to the whole population in Germany with a very complicated methodology, because we are taking care also of the regions. So the sometimes the insured people are a little bit biased in terms of where they live, and so we are taking care also on the regionality, but basically from about 30 millions we extrapolate to 82.
Okay, yeah. Yeah.
And I think in Belgium it's also important because we have, of course, as you well know, lots of uncertainties that can be yeah, giving rise to the results that we have currently. So I think it's important that we work towards this and also try to bootstrap and use this Bayesian methodology to try to inform the uncertainty that is included in these estimates. Certainly, of course, if you look to survival, so we don't have individual data on survival, right? So it's aggregated, and this is also an advantage in terms of privacy, because of course it's very difficult to get individual linked data and information on each individual that lives with cancer in Belgium, what their survival time is. But then I think the first step that we are currently doing is saying, watch out, there is uncertainty related to this. And I think in the next step, we should try to come up with an efficient solution to express these uncertainties as well. Because I think the main limitation when you have many sources of uncertainty is, of course, the computational power that you need and the sensitivity analysis that you need to perform. So it's always a bit more complicated than it sounds. It's not just doing 1,000 iterations and then we'll see what happens. But I think this is something we should strive for in the future, of course.
Yeah, for sure. There is a question in the chat regarding data sources. So Romana is asking, which source would you recommend to use to calculate cancer burden, either cancer registry or claims data? So I guess in France, they have access to both of them easily, probably. Yeah, but I think it's a very difficult question to answer because as you also mentioned, it has different pros and cons, each of them. So the registry being very complete, but not collecting all the data that we might need, and the claims data having maybe like a smaller representative sample, but with more information on the different aspects of the course of the disease. Maybe a combination of the two is the best.
Yes, maybe I can also reflect a bit.
Go ahead.
We also have a register, cancer register in Germany, and they also have the incidence. So they have the records per year, only the new incident cases, and they don't have any information for the old patients, what happened with them. And they also working with survival rates. So we also decided to have a look at the data from the claims data and see if we can use this a little bit more information to come away from this incidence approach, because in a very complicated way they are also estimating the prevalence, and to see if we can come up with another method of estimating prevalence. The results are different from the registry, so which is the best way, I am also not really sure, but yes.
But I think also, if I can add up to this, Elena, I guess in Germany, if I understand correctly, you also have claims data that is linked to certain diagnostic codes, right? So you know
Yes,
if claims
on
data,
individual level data, yeah.
Yeah. For example, in Belgium, we also have individual data, but we don't know for which diagnostic code that a certain claim was made, unless it's really specific medication that can only be used for as only one indication. Then of course you know that this would be linked to cancer, for example. Same for nomenclature codes, and that's, I think, the disadvantage that we have. That claims data is for many diseases we have to use proxies or try to find a solution how we can identify patients with a specific disease. And that's that makes it very difficult in Belgium to use these claims data.
Yeah, indeed. So I see many reflections, regarding that some countries might not have claims data. I guess most of countries have registries, cancer registries. But yeah, linkage between two is also possible. There
Yes.
is one question, and I think maybe we need to close because we are 5 minutes after time, but it's regarding the German data on geographical differential distribution. Is that linked to income or other socioeconomic factor, or mostly environmental?
Yes, it is a mixture. We are still also about to explain or to somehow have a detailed look at the examples and look for explanations, but it is a mixture. It is socioeconomic factors, and also they're connected also with the environmental industrial regions, and yes, one sees it basically in some disease. I didn't show the COPD is very similar pattern like lung cancer, which is definitely a pattern for these lung problems. So yes, but it's difficult only to have a look at one disease. One has to have the whole picture and compare, and then the information is more easy to explain.
Yeah, it's quite a complex matter. So maybe for another.
But follow our page. We will update it as soon as we have all the results.
Thank you. So with this, I would like to thank you very much, the speakers and all the attendees, to participate and the interesting questions. We will try to keep up with this webinar more often, so stay tuned to new webinars and new topics.
Thank you very much. Also, I just want to use, if possible,
go ahead,
to advertise the workshop at the UFA conference that we have gotten accepted on the severity distributions. So please, we will have also further discussions, not only for cancers, but for diabetes, severity distributions for diabetes, or low back pain, neck pain. So our presenters also from Scotland will be there. So we will be happy to see many of you there and continue with the discussions on severity distributions.
Yeah, for sure. All the information on the UFA conference will be on the website, so you can for sure connect with us there as well. Thank you very much. See you.
Thank you. Bye-bye.